I'm Dr. Anthony Martinez, Medical Director of Hepatology at the University of Buffalo in Erie County Medical Center in Buffalo, New York. And today we're talking about one of the most important shifts in chronic Hep B management in years, the move from viral suppression to precision immune control. Now, the recent EASL and AASLD guidelines have completely changed the game. For the first time, quantitative Hep B surface antigen, and not just Hep B DNA, is central to decision-making. We're no longer simply asking, is the virus suppressed? We're asking, is this patient biologically ready for functional cure? Now, for years, nuke therapy was indefinite therapy, especially in Hep B antigen-negative patients. AASLD and EASL's updated guidelines offer new insights into stopping treatment. In general, this can be considered after a long duration of viral suppression and depending on the results of quantitative surface antigen. That is now a commercially available test. Stopping treatment should not be offered if surface antigen is greater than 100 IUs per ml or if advanced fibrosis is present. Now, the decision to stop should involve shared decision-making between both the clinician and the patient. It's essential that the patient be monitored for flares if therapy is stopped, as that can occur. AASLD and EASL guidelines actually differ on this, however. AASLD actually does not recommend stopping, while EASL suggests that it could be considered. However, this is absolutely not for anyone with cirrhosis, prior hepatic decompensation, or the potential for poor follow-up reliability. The second major update is how we approach indeterminate phase patients. In the past, many were monitored indefinitely because they didn't clearly meet treatment criteria. Now, with quantitative Hep B surface antigen, particularly when interpreted alongside ALT, helps us to predict trajectory. This moves us toward true personalization and precision medicine. Instead of binary positive versus negative, we're interpreting antigen burden as a dynamic biomarker. And practically, this may influence frequency of monitoring, HCC surveillance intensity, or the timing of therapy initiation. We're not just reacting to viral load anymore, we're actually reading immune biology. So let's make this real. Suppose we have a 45-year-old male, BE antigen negative. The patient's been on tenofovir for, say, 6 years. The DNA is undetectable for 5 years, but the surface antigen level remains at 800 IUs. Do we stop therapy? Definitely not. Should we continue therapy indefinitely? Maybe. Or do we consider a strategy aimed at antigen reduction? This is where discussions about PEG interferon add-on, siRNA therapies, or emerging functional cure strategies then become relevant. The modern definition of functional cure is Hep B surface antigen loss and undetectable Hep B DNA. This has to be sustained for 24 weeks or more off of therapy. Suppression is good, but suppression isn't cure. The hardest part is expectation management. Patients feel normal, the labs look perfect, but the reservoir persists. Quantitative surface antigen gives us a way to explain that biology. So here's how this translates into practice. Start checking the surface antigen quant in BE antigen negative patients. Track the trends, not just a single value, and consider the 100 or less IU per ml threshold as a potential stopping rule. But again, this is not to be a consideration in people who have cirrhosis. Never stop therapy in a cirrhotic outside of expert supervision. Most importantly, integrate Hep B surface quant into your thinking, not as an add-on test, but as a biological compass. The 2025 guidance doesn't just refine hepatitis B management, it reframes it. We're shifting from lifelong viral suppression to immune-informed decision-making, from is the virus undetectable to is the patient ready for functional cure. Quantitative Hep B surface antigen isn't just another lab. It's the bridge between suppression and cure. And for the first time in decades, that bridge feels real. I hope you found this useful. Thank you for joining us, and we'll see you again.